Welcome to another episode of ICU Doc Talk. Thanks for joining me. Happy New Year's as well, 2023. It's been a bit since I've been able to record an episode, just with life and the holidays and all that stuff. But I thought I had a little time to get back to it. So welcome back, and thanks for waiting for for a new episode. Today I'm just going to answer questions. There's a lot of questions that people ask me on different platforms, and I, of course, cannot get to all the questions, but I think I would just spend a whole episode. Let's just do a grab bag. I'm just going to look at questions people have asked me through email and through TikTok and Instagram, and let's just go through it. And sometimes I don't answer questions because they're hard to answer, but I think meaning it's hard to explain concepts, but I'll just answer whatever I see. I'm just going to go through the list here, and I'll just rattle it off. So let's do it. All right, first question is from Jane, last name withheld, who sent me an email. Jane sent me a very nice email saying how much he or she enjoys my podcast, and shared some other information here. But here's the question that this person asks Jane: do doctors have a responsibility to advocate for better nursing staffing? After all, RN staffing affects the care patients can receive and the outcome, the length of stay, and the complications. I do not think adequate staffing is the MD's responsibility alone. RNs need to be more professionally organized and advocate for this change. In other words, it is the RN's main responsibility to advocate this, as Jane says, but it wouldn't hurt for MDs to concur that RN staffing is inadequate to hospital boards, etc. I am so tired of hospitals claiming the old adage of, quote, patient-centered care and, quote, evidence-based practice, when at the very core of this is adequate staffing and adequately trained staffing, Jane adds, to take the best care of these patients. Research shows that all RN-staffed hospitals result in better patient outcomes, reduced length of stay, fewer complications, and decreased mortality. Jane also mentions that they read American Sickness, which is a book I recommend on here, and they recommended it. That is a good book if you haven't. Okay, so let me kind of back it out, talking about RN staffing. And I say it a lot, and I think I've said it in this podcast, that the people who actually take care of you in the hospital are nurses, right? So, I mean, there's lots of healthcare. I know that's kind of a loaded statement. There's a lot, you could easily refute that. There's things you can say, but what I mean is the people that are actually running patient care, that are actually on the ground, boots on the ground, whatever, that are actually affecting clinical change, physically affecting it and implementing change are the nurses. And the quality of care, if the quality of nursing care is poor, which is definitely affected by staffing ratios, then it doesn't matter how good and I'm talking about inpatient care here, right? Mostly. It doesn't matter how good your doctors are, or your nurse practitioners or whatever. If you don't have proper, adequate nursing care to implement a care plan, then the care suffers, and that's bad for the patient. So I think Jane brings up a good point that, yes, of course, it's like the nursing administration and nurses' responsibility to advocate for this most. Yeah, of course. But everybody should be advocating for safe nursing ratios, right? Particularly in the ICU. Unsafe nursing ratios can result in harm and death of patients, because when nurses have too much of a workload, there's a lot of nuance and a lot of detail that happens in the ICU. And if they are over-encumbered with unsafe staffing ratios, patient care can suffer and harm can 100% happen to patients. So to answer Jane's main question, do doctors have a responsibility to advocate for better nursing staffing? Of course they do. I think doctors do have that responsibility. I don't know how much responsibility, what part of the job that is supposed to be. And honestly, I'm kind of ignorant myself of how to even go about advocating for that. There is much more that I can do as a doctor to advocate for better, rather than just complaining, right? Complaining's fun. Venting and complaining, and it's a nice therapeutic thing to do, to complain, and I can complain about things, but I don't think that's going to be very effective in advocating for better nurse staffing. So I actually don't know what I can do, besides getting more involved in various nursing committees, the various committees that are in a hospital that are in charge of staffing. I don't know what I can do as someone who works at a major academic hospital because I haven't really looked into it, to be honest. So why don't email me and tell me what I can do, and I'll share it here. I'm a little ignorant about what it is that I can do. So, if you're interested in this topic, why don't you email me? You have my ear, and I can talk about it more. All right, let's move on to some other questions. There's a bunch on TikTok, the Q&As. Okay, I'm just going to go through these. I haven't even read these. I'm reading through the first time, and I will answer them. This is from someone on TikTok, Vegas Pecan username. How did you prepare yourself in school / residency to stand out for your critical care fellowship applications? Okay, let me just break the myth that you have to do research to stand out. So I did not do research. Okay, I did like a little tiny bit of research in medical school. I was terrible at it, like bench research. I did some research about breast cancer, 3D modeling of mammary tissues and breast cancer, and I was awful at it. I spent like a whole summer doing it. I came up with all this data, and it was all crap. And I remember the program director, she sat down of the lab to go over my data, and she was so thoroughly unimpressed with the way I presented that she had nothing but silence for me, and then just walked away. And that was her feedback about all that work I had done for like 4 or 5 months. That was it. It never went anywhere after that because it was just bad. Anyway, so my point is that was all the research that I had under my name. I didn't have a single publication in research or anything like that. I think a lot of medical students and residents worry about having research on their CV or their application so that they stand out. Now, you could definitely that can help you stand out for sure, particularly if you're published in a journal and you actually have some good research to talk about. That can definitely like make you stand out. But you don't have to have that. You don't have to have that to be. So, I mean, you got to be a well-rounded candidate. Whether you're a med student, you're looking for residency, or you're a resident and you're looking for a fellowship, and different residencies and fellowships have varying, competitiveness. So, I'm just nip that in the bud. You don't need to stress that you have some research. If research is not your thing, I'll tell you this. Okay, so I interviewed for fellowship at Stanford for critical care fellowship, and I was there during the interview, and I remember I was interviewed with someone who was very well researched person, meaning they had like a lot of research under their name and very well published. And they were like, so tell me about research. Is research your thing? Blah blah. And I was just like, no, I don't have research, and I don't like to do research, and I don't plan on doing a whole lot of research. Just being honest, not BSing, and that went over well. Now that might be a risky thing to do, but I honestly think you should just be your authentic self in an interview as much as possible, so people know what they're getting. And I think that person I think, maybe I could be wrong, but I think from the interview, I think they appreciated my candidness and like, hey, research is not my thing. And you know what? If you are looking, I didn't say this, but it was like the subtext was, hey, if you're looking for someone that's done a lot of research, I'm not your candidate, and you should go with somebody else, right? I'm not a good fit for your program if you're looking for a research-heavy person. Anyway, so what do you think makes you stand out? So writing a personal statement. There's a personal statement I think is I don't think you have to have a perfect personal statement. I've read a lot of personal statements from lots of medical students and residents, and I will tell you this: people in medicine are bad at writing. I've read a lot of personal statements, and most of them are not very good. And that's not their fault. It's just I don't think there's not always a lot of crossover with being a skilled writer and being someone who's medically minded. So I've given lots of feedback about personal statements. And I've read a lot of bad personal statements. I don't think a bad personal statement necessarily hurts you. I think a good personal statement can help you. I think a good personal statement doesn't make you a shoo-in by any means. The point of a personal statement, this is it, okay, is to be memorable to the people deciding if they want to pick you. That's the point of a personal statement. It's not to impress them. So if you're writing a personal statement and you are repeating stuff that's in your CV or your application, that's bad, in my opinion. For one thing, it comes off as bragging, even though you don't intend it. If like halfway through your personal statement, you're like, oh, I was in the Peace Corps and then I did this and this, and you're just rattling things off that you've done. That you shouldn't put stuff like that in your personal statement. For one thing, it's repetitive. The rest of your application already has that information. So that person reading your personal statement already has that information, and it comes off as arrogant. It does. It doesn't mean you're an arrogant person, but it comes off as arrogant and like that you're bragging. So I don't think you should be doing those things in a personal statement. A personal statement, I think the perfect personal statement should be a single story. It should have a beginning and a middle and an end. It should be a story. It should be easy to follow. It should be engaging, and it should be not complicated at all. It should be about one thing. I gave some feedback to someone who was applying to medical school, and they were an impressive candidate. They had like great scores, and their personal statement had so many elements to it. They talked about their daughter that was born with a genetic deficiency, and then a bunch of things, just so many things. My feedback to that person was, and they didn't get into med school their first year. My feedback was, just make this about your daughter. Just make your personal statement just about your daughter. And they did. Now, and that person got a medical school. I don't think it's because their personal statement was better. I think it's just because they applied in a more timely manner. But, their personal statement was excellent after they made that change. So anyway, your personal statement can help you. It can also hurt you if you say something really stupid in there. But I wouldn't fret too much about a personal statement because there's a lot of bad ones out there. And most committees are reading a lot of bad personal statements. But it doesn't mean you're a bad candidate. What does set yourself apart? I think authenticity. I think getting to I think being authentic as much as you can in how you present yourself to a committee through your application process. And then if you're invited for an interview, just being yourself. Being as authentic as possible, being honest, and that's how you connect with people in an interview, right? So I think one of my strengths is through education. Like my grades were pretty good in college, and I was a pretty average medical student, but I think I interviewed well, and I think it's just because I was just laid back and just as authentic as possible. That's my perception. Maybe I wasn't, right? This is all through my own perception. Maybe I wasn't that great. Someone that was interviewed, but I think that I was. And another in a fellowship program that I interviewed at, and the fellowship program that I chose to go to, the interview I had with my personal statement was about my dad who was dying of a lung disease, and so that made me memorable, right? And the first thing the program director of that program asked me when we sat down, first met, he said, "How's your dad?" So he knew me. I was memorable to him, and we had a really, really great chat. It wasn't even an interview. It was just a great interaction between two people. And that's the program I went to for my fellowship, which was an amazing program, and I had an amazing time. And I have so much respect for that person to this day that I still talk to. So I don't know if that answered the question, but we'll leave it at that. All right, next question is from Kate Cisneros, TikTok. Thoughts or advice for someone who is allergic to gas anesthesia, bronchial tubes closed as an infant, now 30. So this is a good question. This is a good example of a question that I don't typically answer because it doesn't make sense to me. And I'm not trying to be derogatory towards this person who's asking this. So they said they're allergic to gas anesthesia. No one's really allergic to gas anesthesia. I've never heard of that, to anesthetic gases. To the typical ones that we use, like sevoflurane, unless they have malignant hyperthermia, then of course they're allergic. And I would assume this person would be talking about that, because if you have malignant hyperthermia, that's usually you lead with that. So it's a confusing question to me. And then bronchial tubes closed as an infant. I don't know what this person means by bronchial tube, and as they're closed as an infant, and now they're 30. Maybe I don't know if they had a lung resection. The reason I think this is a good question to talk about is like, it's so hard to translate what people mean when they're trying. This person obviously, I'm not saying they don't have a legitimate question to ask. They do, but it's hard to understand what people are talking about a lot of times. So this person's saying they have bronchial tubes that are closed. That doesn't make any sense to me. And then being allergic to gas anesthesia doesn't make any sense to me too. I could sit down with this person and ask them a little bit more questions, and I could probably figure out precisely what they are talking about, which is something real, I'm sure. This comes up all the time when trying to give, like, when I'm hearing about someone second or third story that something happened to in a hospital, and they said that this happened and that it was such an outrage. And it's like, it's so hard when you're not there and you don't have someone's medical chart open, and the confusion about language and how we basically in medicine speak another language is so hard to understand sometimes. And so that's why, it's very difficult to give advice or to answer questions when you don't have all of the information at your disposal, and that and I usually assume, people are doing their due diligence, like a medical healthcare worker for that person is doing their due diligence, and that there's just something I'm not understanding. So, to answer this patient questions, I can't answer the question. So, advice for someone who's allergic to gas anesthesia. Well, I guess what I can answer is if you truly are allergic to gas anesthesia, like you have malignant hyperthermia, which is a very deadly disease, we don't have to give you gas. You don't have to have gas for any anesthetic. We can give you IV anesthesia. We can give you continuous infusions of anesthetic that keep you asleep. Easy. That's an easy thing to do. So that's not an obstacle if someone has a problem with gas anesthesia. And we do that all the time. So sometimes we'll just do, and that's called a TIVA, T-I-V-A, a total intravenous anesthetic, where we don't give gas. And we often do that for people that have really severe nausea because gas anesthesia, the volatile anesthetics, can cause nausea. So we do that routinely. So for this person, I would say, ask for a TIVA. Just say, I don't want a gas anesthetic. And most anesthesiologists and most surgeries that you have to have, it can be accommodated for. All right, on to the next question. This is from TikTok by username Adelmum. How concerned are you intubating patients with OSA? OSA is obstructive sleep apnea. So I always want to know if a patient has OSA, if they have sleep apnea, because so approaching someone with OSA with intubation. So OSA is extremely common, right? Many people have it. So it's always good to know it. It doesn't make me, I'm not like overly concerned, like, oh my gosh, they have OSA, how are we going to get their airway? It's usually fairly straightforward. What I'm worried about is when they're waking up, we take the breathing tube out and they obstruct. So we give them, we give a patient a bunch of sedation, and they're sedated when they're waking up. And then they go to the recovery unit, and then they can have a bunch of obstruction, and they can get hypercarbic, right? Their PCO2 can go up, they can get hypoxic, and they can be very obstructive. So I want to know how BiPAP dependent is this person? CPAP, do they wear CPAP at home? Do they need it after the surgery? And then are they going to be difficult to bag mask? Like, am I going to have trouble ventilating this person with it before I put it in a breathing tube? Do I need extra effort to put it in? It's not something that makes me freak out, obviously, because it's so common, but it's definitely something I want to be aware of and I'm more thoughtful of, and that I may need to have a little bit more effort, a little more forethought as I'm approaching the airway to put in a breathing tube. But honestly, it's so common, I barely even notice it anymore because so many people have obstructive sleep apnea. All right, next question is from Sarah Lara Lou. Just experienced my first, quote, awake code blue. Can you explain why or how this happened? Patient presented with chest pressure on exertion, thinking a AAA rupture. So this person's talking about an awake code, and I think what they're talking about is as they're coding a patient, as you're doing chest compressions, there's this phenomena, and it's rare. I don't see it all the time, but when someone goes into cardiac arrest, their heart stops, right? And so blood flow stops. And you immediately, the person immediately goes unconscious and begins to die. Chest compressions literally pump the heart. There might be a little bit of confusion with that. I think sometimes non-medical people think chest compressions are to restart the heart, which they may have that effect by thumping on the heart. But the whole point of doing chest compressions is to act as the heart, to manually compress the heart with your hands from outside the chest with your palms as you're pressing inward. So as you're doing that, you are now pumping the heart, not as good as the heart would, but it is pumping the heart, and it's pumping the organs. And one of those organs is the brain. So sometimes we will see as we pump someone's heart, we do chest compressions, we're starting to perfuse their brain. And when you perfuse the brain, they can start to wake up and they can start to fight you off. And what you see even more, what's even more eerie about this situation that can happen is they fight you off, and as soon as they get the person off that's getting chest compressions, then they immediately go back into cardiac arrest, and they basically kind of quote die. They go back into cardiac arrest and they fall. And honestly, I don't mean any disrespect, but it can look like a marionette puppet suddenly collapsing, like someone is, someone has like a marionette is a puppet. And then the puppet master lets go and they just collapse. That's what it looks like. And then you get back on the chest and you perfuse, and then they wake up again and they fight you off. And it can be very, very alarming to people in the room that haven't seen it before. And sometimes these people eventually die. We let them go. And it can be very alarming because it was like, well, they were awake and they were fighting us off. And it's like, well, but we weren't able to reverse the thing that was killing them. So we eventually just had to stop. So I mean that's why it happens. That's why you can get this phenomenon that it looks like that. All right, let's just go down the list. This is a question from Patrick Highsmith 6. Hi, my name is Rick Highsmith. Is there anesthesia risk? What? I have no idea. I don't know what I don't know what the person's saying. Next question. Okay, this is from Jen Cupcakes 88. What happens when a healthy 25 to 35-year-old age has an accidental fentanyl overdose? Seems to be such a huge problem among us. Yeah, so I'm not an expert on the fentanyl, epidemic that's going on. Epidemiological, I don't know how deep. I haven't looked into it myself, in the community in the United States. I know it's happening. The news sensationalizes things, and I haven't done my due diligence to looking beyond what the sensational news headlines are to really know what the numbers are on the fentanyl epidemic. I'm not denying that it's a thing that's not happening. I just don't know the extent. Anyway, this person's asking what happens when a healthy person has an accidental fentanyl overdose. So it's the same thing that happens to anybody that has an opiate overdose. Opiate overdose causes respiratory depression. That is what someone dies of when they die of overdose. If they die of overdose, overdose doesn't mean you die, but it means your opiates make you stop caring about breathing. That's what it is. Someone can also aspirate, vomit, and that can also be deadly to them as well. But fentanyl is an opiate, just like anything else, just like heroin, just like morphine. It's very fast acting. It's very powerful. And that's what's happening. And it can happen to anybody. It doesn't matter if you're healthy. It doesn't matter if you're young or old. But that's what an overdose is doing. It's making you not care about breathing. And you stop breathing and you get hypercarbic and then hypoxemic, and then you can die from that. Next question. Let's see. This is from Y. Vovanderhoek. Are there times you found the procedure proposed as risky and refused on ethical grounds because you did not see it to be the patient's best interest? Yeah. So, I mean, I'm not really a proceduralist, right? I'm not a surgeon. I don't do a whole lot of procedure. Well, I do line placements, but one thing that I do that is unique is I put people on ECMO, right? I put these big catheters in someone's groin, typically, or their neck, and it's basically a heart-lung bypass machine, and it pumps blood around for them. And it, it's to save someone's life. That's very sick. So have I ever refused to do this on ethical grounds? Yes, definitely. Here's one example. So I was called down to the emergency department. So sometimes when a patient comes in and they're resuscitating the patient and they're doing chest compressions, sometimes the ER physician will call me as the ECMO attending to come down and assess the patient for ECMO candidacy. And I will go down and I will look at the patient. So we had a patient who seemed fairly young. They were actively doing chest compressions. Maybe the patient was in their 30s, could have been. And the report that we received from EMS is that the patient choked on a sandwich and had aspirated it and went into arrest, and it was unwitnessed arrest. But then they were found, and chest compressions started, and they were brought in. And chest compressions had been going on for maybe 45 minutes or something like that. So I said no to putting that patient on ECMO. And I have to do that often, to say no to ECMO. Through COVID pandemic, through the height of the Omicron and Delta, I was getting consults all the time for putting patients on ECMO. And I said no more often than I said yes. And there's many, many, many reasons to say no for ECMO that are a little too complex. I should probably do a whole episode about it right now. And it sounds cruel, right? Just no, and I leave, right? I say this patient is, I announce to the room, in this case, this patient is not a candidate for ECMO. And I usually say why. I say because it's an unwitnessed arrest, and it's a PEA arrest, a pulseless electrical activity arrest. And the reason is because the patient probably does not have a good chance of meaningful neurological recovery. And you do not put patients on ECMO that are going to be brain dead or have a stroke. You don't do that because there's no reason to, because they're going to be dead anyway. So I usually announce why, and then I leave. And I'm done, and I honestly don't think about it again, too much. ECMO is a resource-intensive thing that we use, and we have to be judicious with how we use it. And we don't want to get in a situation where we put someone on ECMO and they don't have a way to get off of it. That creates all sorts of new ethical conundrums, because we're basically keeping a body alive that shouldn't be alive. And then the family is conflicted. The family doesn't know what to do. They can feel like they're killing their loved one. It gets very complicated very fast. And sometimes up front, we need to just say no, and we move on. And that is a reality. That is a reality. So we are very selective with our ECMO criteria. And there's a lot more nuance to it than I'm just saying with that case. But yes, I have declined to do things for ethical grounds. Another person asks, CPH 706, where did you do your training? That is not I get that question all the time, and I will never answer that question because I do not want to give personal information about myself. Next question by Mitchell Cook 095. Are you familiar with LIDCO monitors? They measure hemodynamics. I would love to know more about cardiac output, cardiac index, systemic vascular resistance index, stroke volume index, etc. How it guides treatment. So it's a great question. So I work in a cardiac ICU, and we use these monitors all the time. And I've used LIDCO or FlowTrack, and these are monitors designed. They use the contours of an arterial line blood pressure transducer to report a cardiac index or cardiac output. Cardiac output, if you're familiar, is the stroke time someone's heart rate. A cardiac output is a good indicator, and a cardiac index it's a cardiac output, but it's normalized to body surface area. So it's more normalized. It's not a raw number. So, a normal cardiac index would be like, 2 to 4, 2.5 to 4, something like that, 2.5 to 5. Less than 2.5, in my opinion, is, a little bit low. And I do use these monitors. I used to, we use PA catheters and thermal dilution to monitor someone's cardiac index because it helps guide our therapies. Does this person still need mechanical circulatory devices? Do they still need an Impella? Do they still need epinephrine? What happens if we turn off the milrinone? What happens if we do that? And it helps guide our therapy along with other things, right? You can calculate a FIC. You can look at your lactate. There's many. The whole point, I think, with a LIDCO monitor or FlowTrack monitor, for one thing, they're not always reliable. It has to be taken in context of what's going on with the patient. If it looks like it's trending with the rest of your stuff, then it's reliable and I use it. But they're not always reliable in every single patient that you use them on. So you just need to be careful and use them cautiously and not hang your hat on one value from like a LIDCO or FlowTrack monitor. And SVRI is the systemic vascular resistance. It's the same. It's the same. That's the resistance of your vascular system. And that is also a good number that can help guide things. So I do use these monitors. I think they're helpful. I don't think you have to have them. I think there are other things you can use, like getting an SVO2 and calculating a FIC score and a lactate. I mean, you can put a central line in and an arterial line and get SVO2s and a lactate. You can trend those things and then see how fluid responsive someone is. And that can also help you know what perfusion is and know what someone's cardiac index is. And so there's many ways you can go about it. People could be dogmatic and think that their way is best, and it's not. I don't think there's a way that's better than another way. All right, next question. Keontae0620. Have you ever dealt with sickle cell patients like myself? I have dealt with sickle cell. Not a whole lot. So it's sickle cell anemia and sickle cell crisis affects mostly black people of African descent so sickle cells, literally you have red blood cells that are shaped like sickles rather than being nice and round. And it's protected of malaria. So that's why it stayed in the gene pool, because it helped protect people from dying of malaria. But unfortunately, when people get dehydrated, when they have this, they can get dehydrated, they can have pain crises where the sickle cells don't flow very well, and you can get acute chest pain syndrome, and it can be deadly. And it's probably one of the most painful things that a person can experience. These people are in an extreme amount of pain. And then there's the people that have sickle cell disease, and they're usually Black Americans. Where I live in America, they're usually Black, and then these patients have to deal with the stereotype of Black people being drug seekers, and maybe not being drug seekers necessarily, but not being believed that they're in pain, right? So they have to deal with that stigma, which I do think is real. So it's a double hit, right? They may not be believed that they're in pain, and then they have to deal with the racial stigma, just frank racism against them. I'm not saying that happens everywhere, but it happens, believe me. But I don't have sickle cell patients a lot where I practice. I have had in other cities, and the rule is believe them and give them as much pain medications that they need. That's it. Okay. And then definitely keep them hydrated and make sure they're on what's the medication? Hydroxyurea that can help with sickling. But I'm no expert on sickle cell anemia, so I'll just leave it at that. I don't want to say anything wrong. It sounds stupid, right? Okay, here's another question from Gran Farley 760. Have you heard of Japanese yew poisoning with the intent of self-harm? How did you treat the patient? We had one come in and they mentioned using ECMO. So I haven't heard of that particularly. Not that, but suicide attempts with certain drugs can definitely warrant ECMO. The two that come to mind are, I guess the one that comes to mind is Wellbutrin. People that overdose on that can have cardiovascular collapse, and they can die and go to cardiac arrest really quickly. So someone with really bad Wellbutrin overdose, possibly they may need to be, and they're often young people, they may need to be emergently placed on ECMO. Lithium is also another one. They don't need to be put on ECMO, but if someone has lithium overdose, they need to put them on dialysis immediately, or they can die, because the only way to get rid of that excess lithium is through dialysis. There's a lot of medications, unfortunately, that people can use to commit suicide, but I'll just leave that at that. All right, here's another question. This is about a book. K. Campion 19. Is there any chance you've read Gideon the Ninth by Tamsin Murray? It's a great fantasy sci-fi, and I'd love to hear your thoughts if you have. So, I have read that book, and I hated it. I hated it so much. So, I'm sorry to burst this person's bubble. I probably won't answer this on TikTok because I don't want to bum them out. It's a very popular book. Maybe if you're listening to this, you may have heard of it. A very talented writer, it's called Gideon the Ninth, by Tamsin Muir, M-U-I-R, and she's a very good writer. It's very good writing. But I absolutely hated the book. I thought it was asking way too. I thought there was way too many characters. The plotting was crazy. Anyway, it just wasn't a good book, and I hated it. Which you don't hate a lot of books that I read. Anyway, let's move on. Let's see. Here's one from Custom K9. Have you experienced seeing a patient's veins run away from the IV needle when you're doing one with ultrasound? It happens with mine a lot. So running away, I wouldn't describe it as that way. I think veins can roll as you're trying. That's probably what this person means. As you're trying to, putting in an IV it takes a lot of practice to get good at it. Like someone who's good at putting in an IV, they make it look real easy. But it takes practice. You gotta flatten you have to make the vein taut with your one hand, make it nice and taut so it doesn't roll. That's key. With my thumb, I kind of put my hand on the skin where the vein is and I pull it to make the skin taut. And then with the other hand, with the needle, you bring it in as parallel as possible to the vein, and you poke just a little bit. You start to see some blood come in, and then you advance like a millimeter to make sure that the catheter is also within the vessel before you thread it off. If you poke and you get blood, sometimes you just have the bevel of the needle in the vessel, but not the catheter. And then if you try to thread it off, it'll infiltrate. So that's very, very important. So there you have it. All right, let's move on to the book. This book, I read it probably like 2 years ago. It's called Why We're Polarized by Ezra Klein. He's the creator of Vox News Channel, VOX Vox. And it's a pretty good book. This was published in January 2021. No, that's not when it was published. It's January 2020. It's about 300 pages. It's a simple read, not too long. And basically, Klein explains the polarization of American politics in a really accurate and concise way. The first thing I have to say is read this book. It's good. I would follow it up with, talking to you, read this book. Every American should read this book or a book similar to it. Now, I don't believe Klein has come up with anything entirely new with this book, but the way he presents the information is really palatable, it's concise, and it's very easy to understand. If you're even remotely politically aware, you've probably had theories about American polarization kicking around in your head, but maybe you haven't been able to fully articulate those ideas. And I think Klein does that in this book. I think he articulates what we're all kind of thinking, but can't quite say it. He argues that once upon a time, there wasn't that big of a difference between the two American political parties. In fact, politicians in the 1950s were begging for more polarizations so that voters had more choice, because they actually were kind of the same on either side of the aisle. It was extremely common to split your ticket and vote blue and then red and then blue as you go down. At the same time, the media had to appeal to wide audiences because viewers had little choice in where they got their news. So media had to stay broad to stay engaging. Identity was less intertwined with politics. What happened since then is a stacking of identities, a lining up of personal identities. As media fractured and started to chase different ideologies, they realized they could shrink their audience and still stay relevant and profitable in the age of social media. So to be a Republican or a Democrat these days is much more about who a person feels they are at the very core of their being. When engaging in a debate, it is no longer an argument over ideology or policy, but it's an argument over identity. And here's the tricky thing. You cannot change someone's identity through discourse. That's why you run into so many walls talking to people. Everything is about identity. Modern politicians understand this really well. They know that negative partisanship has a much more galvanizing force than positive partisanship, meaning saying everything is bad about the other opposition party is much more galvanizing than being positive about your own party. People care about winning. I know it's very basic, but they do. They care about their team winning and being on the winning team. The motivation is that the other team loses. Sports mentality is most definitely at play. Because of this, facts have become an impotent tool in the hands of a do-good debater. Facts don't really matter, right? If you've noticed that, all people will see the facts only within the boundaries of their identity, only to confirm their own biases. Klein puts forth some good research about how our cognition actually suffers when our political identities get involved. And that doesn't matter if you're on the left or the right. Your ideology makes you make cognitive errors. It does. And there's some good studies he talks about. But that doesn't mean the identity is symmetrical in the two parties. The Republican Party is clearly, in my opinion, a more homogeneous identity than the Democratic Party. I think I could be challenged on that, and I think there's some exceptions. In this way, Republican politicians can dive deeper into their base of mostly white Americans and tug on those feelings to get them to hate the other side pretty easily. Democrats, on the other hand, are a more diverse coalition, which must appeal more widely to the base or risk alienating their own party. Since Republicans don't need to appeal to more people, only to the land that those less people occupy, they can maintain national power as a majority despite representing a shrinking majority or minority of American identity. The change in American demography is what has driven the polarization, is what Klein argues. White population is shrinking, brown population is growing. These are tectonic forces that are driving people deeper into their identities to protect and to create a false zero-sum political landscape. I could go on, and I think the book does. What I've discussed is I think is an oversimplification, and I think the book is an oversimplification, but I think it's a good model about what probably is going on. But I do think it is more complex than what I've talked about here and what the book talks about. But if you're interested in why things are so bad, why they're so polarized right now, this is a great book to start with. And there's other books to read about this topic. So this is called Why We're Polarized by Ezra Klein. All right, I'm going to wrap it up. Thanks for listening. Send me an email at icudoctorecmo@gmail.com if you have any topics or suggestions you want me to do a podcast about. And my handle on TikTok is icudoctor, and I'm on Instagram at icudoctortiktok. Check me out, and please read, review, share, and I'll try to get back to you soon. Thanks.